Good morning. First of all, I must apologize for the technical hitch. The gremlins have been visiting you over there, and I believe you've been having problems with your computer. So let's try to get started and get it moving. The presentation is entitled New Horizons in Orthodontics. It introduces a new approach to twin block functional therapy and represents a revolution in dentofacial orthopedics from mixed dentition to adult therapy. This presents an update of my work with twin blocks to illustrate the implications for advancing the future of orthodontics. So I'm presenting this from my home in Scotland, and it is to introduce a new series of education with the title New Horizons in Orthodontics. I hope you enjoy the presentation and that we don't have any more gremlins. Okay. First of all, just to show you where I'm coming from, this is where I live. It's a village on the east coast of Scotland, and it's named after the golf course, which is London Links in the background. So my home is just in that little village there. It's a quiet little backwater. And this is a rural area of Scotland on the east coast, very near St Andrews, which is the home of golf, and we're also close to Edinburgh. So we're in a quiet little place. But let's get started. When we plan treatment, we have to decide, does this patient need orthodontics or orthopedics? Now, the patient on the left is definitely an orthodontic case. There is no way we can fit all of these teeth in that mouth. This patient needs extractions, followed by braces to fix his teeth. As you can see, his face is otherwise perfectly normal. The patient on the right has an unusual face. This is definitely an orthopedic case. The teeth are no big deal, but to treat this patient, we must treat the face, not just the teeth. He needs a functional appliance to fix his face. Let me explain where that picture comes from. My son is an artist, and he did this painting when he was about 15 years old. Okay, so we thank him for his contribution. These are just fundamental questions at the start of treatment when we choose between orthodontics or orthopedics. For generations in the 20th century, we followed the fixed philosophy, and we believed that the skeletal pattern is genetically predetermined, and therefore we can't change it. Fixed appliances fix teeth. They achieve dental perfection, and if that is our objective, we choose fixed appliances. We attach little handles to the teeth and apply gentle forces measured in ounces to move the teeth through alveolar bone. Following that philosophy, fixed appliances do not attempt to maximize growth potential. They are simply moving the teeth. But functional appliances create aesthetic faces. When we choose a functional appliance, we are treating the face. In twin block therapy, we use the forces of occlusion to correct the malocclusion. These are measured in pounds and are not designed to move the teeth. They are designed to treat the face by stimulating growth changes to improve the pattern of facial growth. The difference in treatment philosophy is quite fundamental. So, in treatment of severe Class 2 Division 1 malocclusion, sometimes we have to choose between orthodontics, orthopedics, or surgery. When I developed twin blocks in 1977, I observed dramatic facial changes within the first 3 months of treatment. This patient had a 17 mm overjet, and her dull facial expression is typical of a patient with mandibular retrusion and a restricted airway. These patients cannot breathe properly. In my early courses, I taught this theme. The face of orthodontics is changing, to recognize the potential of dentofacial orthopedics. The profile change is equally dramatic after 4 months and 11 months treatment, and we have changed the face at this stage. So let's look at the malocclusion that we're dealing with. We have a 17 mm overjet and buccal occlusion of the upper premolars. I love to ask this question: how would you treat this patient without surgery? Because that is the challenge. The occlusal inclined plane is the functional mechanism of the natural dentition. Twin blocks guide the mandible forward on occlusal inclined planes for functional correction of a class 2 malocclusion. Twin blocks use the forces of occlusion to correct the malocclusion. Whenever possible, I like to design appliances that are patient-friendly. These are invisible twin blocks designed to correct an uncrowded class 2 division 1 malocclusion by expanding the maxilla as we advance the mandible to correct the distal occlusion and reduce the overjet. For an overjet of more than 10 mm, we cannot register an edge-to-edge bite on the incisors, and the initial activation is between 8 and 10 mm. So this is a little bite gauge that we use to register the bite, and for a large overjet, this is how we register the upper teeth in the left-hand groove, and the lower teeth bite into the groove. The lower incisors bite into the other groove. And then, in this case, after 4 months, the twin blocks were reactivated to an edge-to-edge incisor relationship by adding acrylic to the mesial incline of the upper blocks. That's how we deal with very large overjets. The occlusion is corrected to class 1 after 11 months treatment. We don't have any brackets in our practice that will achieve this result in this time scale, or for that matter, in any time scale. Cephalometric analysis shows a combination of maxillary protrusion and mandibular retrusion. This patient is being treated during the pubertal growth spurt. There are 3 phases of correction in twin block functional therapy. Phase 1 is muscle adaptation, which occurs in the first 3 months of treatment. Bony adaptation occurs within 1 year. And in this case, in 11 months, this superimposition shows the change in the position of the mandible after 11 months treatment. Now, initially when I started to use twin blocks and I saw these rapid changes, I didn't really believe they would be permanent. I thought there must be posture involved here. But now, with the benefit of hindsight, I know that there is consolidation, and the third phase is after retention. I always recommend a functional retainer. Alternatively, if functional therapy is completed in mixed dentition, twin blocks may be worn at night to retain the corrected occlusion as permanent teeth erupt. This shows the profile development before treatment, after 4 months, 11 months, and 5 years later out of retention. So true enough, these results proved to be stable. This is the before and after tracings for this patient over a period of 2 years, and mandibular growth exceeded maxillary growth by 11 millimeters. So that is how we corrected that large overjet. We should not lose sight of the fact that Pierre Robin developed the monoblock to treat patients who had difficulty in breathing due to severe mandibular retrusion, the Pierre Robin syndrome. This was the first sleep apnea appliance, the monoblock, in 1902. We've been using functional appliances for more than a century. The unique benefits of twin block functional therapy are now inescapable, as they are supported by scientific research at cellular and molecular levels. New technology has improved the evaluation of results. Three-dimensional studies authenticate the claims of twin blocks to deliver holistic benefits to patients beyond the scope of conventional orthodontic techniques. This is especially important in improving the airway. What benefits can we hope for from twin block functional therapy? Improved facial harmony, better occlusion, improved airway, less risk of sleep apnea, improved alertness in school. Helping patients to breathe better is perhaps the most important benefit of orthodontics or orthopedic treatment, and certainly of twin block therapy. This can change a patient's life by producing holistic benefits to health that will last for a lifetime. Improvement in the pharyngeal airway after twin block therapy is now confirmed in research. This study was published in the Journal of Orthodontic Science. Cephalometric evaluation of hyoid bone position and pharyngeal spaces following treatment with the twin block appliance. There was a significant increase in the pharyngeal airway in all 3 groups: hypodivergent, normodivergent, and hyperdivergent. Now, let's look at the clinical technique. The functional treatment objective is a simple clinical guideline for case selection. We take photographs on the patient's first visit, first with the teeth in occlusion and the mandible retruded, then with the mandible advanced and lips closed together. If the profile improves with the mandible advanced, what you see is what you get. The photographs with the mandible postured forward are an accurate prediction of the end result. So that helps us in case selection. Before treatment, we can observe the facial change in 3 dimensions to enable us to predict the end result. So that's how we select our cases. If we don't like the profile when the patient postures forward, that is not a functional case. That is probably an orthodontic case. It helps us select the method of treatment. We look now at the clinical management of a Class 2 Division 1 malocclusion with deep overbite, and this patient is treated during the pubertal growth spurt. That's always the best time to get the best growth response. We have a narrow maxilla with reduced intercanine width, and this locks the mandible in distal occlusion. The overjet is 10 millimeters with a full unit distal occlusion. No crowding, this is a perfect case for twin block therapy. Now, in this case, with an overjet of 10 millimeters, we can register the bite edge to edge. And with this bite gauge, we have 2 millimeters interincisal clearance. For an overjet of up to 10 millimeters, the construction bite is normally edge to edge on the incisors, 2 millimeters open, provided the patient can comfortably occlude edge to edge on the incisors. I like to see the patient able to move the lower incisors ahead of the upper incisors by 2 millimeters or so, and then I know I can register the bite at edge to edge. The activation should be no more than 70% of the total protrusive path of the mandible to remain within the physiological range of movement for the individual patient. Therefore, if the patient can barely close edge to edge, you might take them back 2 or 3 millimeters for the bite registration. The vertical activation with 2 millimeters between the incisors is equivalent to 5 millimeters in the premolar region. The bite should be opened slightly beyond the freeway space. So this is a typical bite registration we see here. These diagrams show the management of the vertical dimension in treatment of deep overbite and anterior open bite on the right. Deep overbite is corrected by progressively trimming the upper block, as you see in the diagrams on the left. This is to encourage eruption of the lower molars. We progressively trim the upper block. The inclined plane must remain intact to maintain the forward guidance of the mandible. But progressively we trim the block so that we are allowing the lower molars to erupt during the twin block phase. At each visit, we take a little more off the upper block. In treatment of anterior open bite, the occlusal cover remains intact, and we want to apply intrusive forces to the upper teeth. We may apply these forces by the addition of vertical intraoral elastics to intrude the upper teeth, while the incisors are free to erupt. That's how we handle anterior open bite. Now, sagittal correction and reduction of the overjet always occurs before vertical development to reduce the overbite by eruption of the lower molars. It does help if you place separating elastics in the molar contact with the second premolar. That will free, you do that right at the start of treatment, and that helps to free the lower molar to erupt. So at the end of the twin block phase, the overjet and overbite should be corrected and the molars in class 1 occlusion. So progressively we are allowing eruption of posterior teeth, and this is to gain molar contact initially, and then we trim to the lower block to reduce the thickness of the lower block so that the premolars also can begin to erupt at the end of the twin block phase. It is important to support the corrected overjet and overbite when twin blocks are left out. A retainer with an anterior inclined plane may be fitted and is worn full time while the premolars and canines erupt until the occlusion of the posterior teeth is fully established. That is if we're treating the patient entirely with removable appliances, twin blocks followed by a support appliance. And this is suitable for patients with good arch form and no crowding. If there is crowding or irregularity of the anterior teeth, we may then move into fixed appliances if required to finish the case. But in this case, we used a removable support appliance with an anterior inclined plane just to support the occlusion as the buccal segments erupt into full contact. Sorry, I'll go back. Okay. This may be used for nighttime retention if necessary. This is the occlusion out of retention nearly 17 years old. This shows the rapid improvement in the profile after 6 months treatment, and we see the stability of the end result 6 years later. We look now at management of crowding and lingual arch development. This girl presents mandibular retrusion with labial crowding in both arches. The lower incisors are 4 millimeters lingual to the apogonian line. That is always a guide I use in determining whether or not to advance lower incisors. Ideally, in an ideal occlusion, the lower incisors are 1 to 3 millimeters ahead of the APO line. If on the lateral skull X-ray we see that the lower incisors are lingually displaced, that is an indication to advance the lower incisors, and we would do that in the first stage of arch development. There is a large overjet, deep overbite, with a lower canine blocked out of the arch. We must deal with crowding before fitting twin blocks. In this case, I used a lower bihelix appliance for lingual arch development to accommodate the blocked out lower canine. And a simple fixed appliance was used on the upper anterior teeth to align the arches before we proceed to the twin block phase. The lower incisors have been proclined to accommodate the lower canine without advancing the mandible, so we will not see an improvement in the profile at this stage. The lower lip is rolled forward as we advance the lower incisors. Now we are ready to start the twin block stage. This is the typical construction bite for an overjet of up to 10 millimeters, registered edge to edge on the incisors with 2 millimeters interincisal space. The appliances are designed for full-time wear, including for eating, and I like to design appliances that are aesthetic and comfortable. For example, I seldom need to add a labial bow, so that the appliances are almost invisible. This improves patient cooperation. The appliances are comfortable, aesthetic, and efficient. Now, how can we ensure that the patient will wear these appliances 24 hours a day? Because that's what they're designed for. And I taught this during my teleconference in Chicago. I'm sorry you were not able to see the rest of it, but what I explained was, how can we ensure the patient will wear these appliances 24 hours a day? Well, when you fit the appliances, if you make them really snug and tight on the teeth, and with the clasps that I use on the lower premolars, these are delta clasps. I designed delta clasps in the 1980s. and it really gives excellent retention. Now, when you fit these appliances on the first day, you don't need to tell the patient that they are removable. Now, many people around the world adopted that method. And if the patient doesn't know that they're removable and they're really snug and tight, they cannot take them out. We have not instructed them how to take them out. We could even, for example, if we have C-clasps, we could attach these with composite. The whole point is, for the first few days, the patient will adapt to wearing the appliances 24 hours a day. If you want to go further than that, you can add a little cement, a temporary cement, so that the patient absolutely cannot remove the appliances during the first few days. They adapt to eating, speaking, wearing them full time, and that can improve your cooperation with removable appliances by 80%. I have had that feedback from patients abroad who use that system. Now, within 8 weeks of fitting twin blocks, the profile has improved as the mandible postures forward. Of course, the patient has not been wearing these full time without taking them out for 8 weeks, only for the first few days to introduce full-time wear. But there is that dramatic change in the profile. It's typical in the early stages of treatment, and it's due to muscle adaptation when the patient adapts to posturing forward. In the twin block phase, correction of overjet and distal occlusion is by mandibular advancement, in this case after 8 months treatment. This is the settled occlusion, 18 months out of retention. So in an uncrowded dentition with good arch form, you don't need to go on to a second phase of treatment. Only retention. In fact, you may fit a separate retainer, or alternatively, the patient can continue to wear the twin blocks at night. By that time, you will have reduced the thickness of the blocks, and you may even remove the blocks, and the patient will wear them just as retainers at night. After 2 months with twin blocks, we see the preview of the end result out of retention 3 years later. Can we treat maxillary protrusion with twin blocks? This is an example of a patient with a severe Class 2 Division 1 malocclusion due to maxillary protrusion. This patient was treated in India by Dr. Dilip Patel. This is a convincing example of treatment of severe maxillary protrusion after 1 year's treatment. If the profile improves when the mandible is advanced, that is an indication for functional mandibular advancement. And the problem may either be mandibular retrusion or maxillary protrusion, or in many cases, a combination of both factors. So this patient was treated with twin blocks in late mixed dentition, and treatment was completed in 1 year. The lateral skull radiograph shows an improvement in the pharyngeal airway as a result of advancing the mandible. That is a permanent improvement for a patient, and it may be the most important change that we produce for a patient, helping them to breathe better, because that is permanent. That increase in pharyngeal airway is permanent. The position of the condyle in the glenoid fossa is monitored by measuring the distance from the condyle to the auditory canal. In this case, the distance is the same before and after treatment, confirming that the condyle is relocated in the glenoid fossa. A very important aspect of twin block therapy is not to take the twin blocks out too early. I like to see a minimum of 6 months treatment, but in many cases 9 months, because we are allowing time for compensatory mandibular growth. In this case, you see that the lower molars were horizontal before treatment, and increased growth of the mandibular corpus has created space to accommodate the third molars after 1 year. So I would say the time in twin blocks typically would be, in a mild case, 6 months, moderate 10 millimeter overjet, 9 months, and a larger overjet, a year or more if necessary. But don't shorten the treatment if you are not clear that the patient has had time for compensatory mandibular growth. Now, do functional appliances produce supplementary growth of the mandible? We have agonized over this question for the past century. Do functional appliances make the mandible grow? What is the evidence? When I first started to use twin blocks, I was amazed at the speed of the facial changes I saw in my patients within the first few months of treatment, and I went to the literature to see if there was any similar research, and the closest equivalent I could find was McNamara's animal experiments with the macaca mulatta monkey. McNamara used a fixed incline plane to advance the mandible to promote increased mandibular growth. This was the same mechanism as the occlusal incline planes in twin blocks. In an electromyographic study, he recorded significant increase in muscle activity in the entire range of craniofacial muscles. Increased muscle activity accounted for the stimulus to increase mandibular growth by using the forces of occlusion to advance the mandible. This graph represents the response of muscle function during the first 3 months after the appliance was fitted to advance the mandible. Now, at this point, I want you to experience this for yourselves, sitting at home. What I want you to do is to move your mandible forward as far as you comfortably can. And when you do that, just move it around a little and feel the vibration, the activity in the muscles, not simply around the mouth, but you will find that the masseter muscle gets tense, and the same applies to the craniofacial, the temporalis, and all of these muscles are working harder when you advance the mandible. And it's that muscle power that corrects the malocclusion. We are using the forces of occlusion to correct the malocclusion. Now, on this graph, the straight line before the appliance was fitted represents an equilibrium in muscle activity. Immediately when the twin blocks are fitted, the muscle activity increases. That's what you feel when you move your mandible forward. And after 3 weeks, the muscle activity increases for the first 3 weeks. And after 3 weeks, the graph levels off. This is a new position of equilibrium in muscle activity, but it's at a higher level. And then after 4 weeks at that level, the muscle activity then steadily reduces to the same level as before treatment. This cycle is completed in 3 months. Now, it was intriguing for me to note that the cycle of muscle activity was identical to the response I observed, the rapid response in the first 3 months of twin block therapy. And that is the period when the muscles adapt to the new forward position of the mandible. McNamara recorded the difference in growth response by histological examination to demonstrate the control animal. There is a uniform layer of condylar cartilage on the condyle and a normal appearance of the temporomandibular joint. In the experimental animal, there is thickening of the condylar cartilage in posterior, superior, and superior area due to increased cellular mitosis in the pre-chondroblastic layer. That is the layer under the cellular layer that allows increased growth of the condyle. In the glenoid fossa, new bone was formed on the mesial aspect of the postglenoid spine. The animal responded to functional stimulus by bony adaptation in the condyle and the glenoid fossa. So animal experiments provided the first scientific evidence that functional mandibular protrusion could produce increased mandibular growth in an era when the available evidence supported a strict genetic paradigm. It was not perceived possible to enhance mandibular growth beyond the strict limits of a preordained inherited pattern. McNamara recorded a significant increase in condylar growth in the experimental animal, measuring both the vertical and horizontal components and the resulting increase in the length of the mandible along the growth axis of the condyle. We would not be permitted today to do these experiments, but they did establish the ground rules for functional therapy. Now, this justified further clinical research on the growth response to functional therapy. And this is one of the best studies on twin blocks by Mills and McCulloch. Christine Mills in her orthodontic practice in Vancouver, using matched controls from the Burlington growth study. On the left is the control growth. The red line indicates the period of twin block therapy, that's on the right. And the blue line is 3 years post-treatment. So these tracings were taken over the same period of time. And in the control patients, the mandible, the condyle grows vertically. But in the twin block patients, the condyle grows distally to the red line during the twin block phase. And the study showed that the growth increased to 3 times the distance of the controls during the twin block phase. And it continued in the post-treatment phase. In the post-treatment phase, the corpus of the mandible increased as the mandible remodels to its original shape after the twin block stage. So these results are very similar to the earlier animal experiments. These are the conclusions of this study. The mandibular unit length increased nearly 3 times as much in the twin block group compared to the controls. Much of the skeletal improvement is related to increase in mandibular length, and these changes are for the most part stable 3 years post-treatment. So other studies have been done since that time to confirm that, we can grow the mandible. That is the whole objective of functional therapy, using a full-time functional appliance. This is an interesting MRI study in India supervised by Professor Karbanda. Temporomandibular joint adaptations following two-phase therapy, a magnetic resonance imaging study. It illustrates the change in shape of the condyle during twin block therapy in response to functional therapy. Before treatment, there is an anterior notch on the head of the condyle and a flat contour on the posterior superior surface. During treatment, the anterior notch is lost, indicating proliferative activity due to accelerated growth of the condyle. After treatment, the condyle remodels to its original shape and is relocated correctly in the glenoid fossa. In light of that new knowledge, we now review the treatment of a severe Class 2 Division 1 malocclusion. How would you treat this patient? This is a challenging malocclusion that cannot be treated by orthodontics. The choice would be orthodontics, orthopedics, or surgery. This patient was treated by a fellow Scot, Dr. Forbes Leishman, who attended the first twin block course in 1979. He later practiced in New Zealand, where he combined twin blocks with fixed appliances, and he found that he had many referrals because he was combining the functional and fixed phases and achieving excellent results like this. This is the profile before and after treatment, and later, 3 years later, at age 17. Treatment coincided with the pubertal growth spurt, which accounts for an excellent mandibular response with condylar extension and distal growth of the condyle during the twin block phase on the left. In the post-treatment phase, there is a significant increase in mandibular corpus length as the mandibular ramus remodels to its original shape. Another of Dr. Leishman's patients is treated in the post-pubertal stage. She was 14.5 years old before starting treatment. Do you think she grew well? Again, he achieves an excellent dental occlusion. Twin blocks followed by fixed appliances. So this is the improvement in the profile. Would you be happy with this profile change? And do you think she grew well? She grew differently. In the post-pubertal growth stage, there is no condylar extension, but the gonial angle has increased significantly during the twin block stage, indicating that the condyle grew distally. This also contributes to forward positioning of the mandible to improve the profile. The shape of the face has significantly improved. The vertical dimension has increased by downward and forward positioning of the mandible. Now, one word of caution. If you treat a patient in post-pubertal phase, you need to give them longer in twin blocks to make sure that you allow enough time for the bony remodeling that is taking place. Many of these patients look more alert after treatment. We see this in their eyes, and this may be a secondary effect as we improve the airway by advancing the mandible. So, removable appliances designed for full-time wear. I like to design these appliances that are aesthetic and comfortable. If you don't need a labial bow to retract spaced proclined teeth, you don't need to add it. This improves patient cooperation. At this point, I want to introduce you to my technician and friend. He has a famous name, James Watt, who invented the internal combustion engine. And we worked together for 50 years. Sadly, he is no longer with us, but he made a significant contribution and supported me in practice for many years. Now here we are sitting in our sun lounge, which is where I'm sitting right now. So maybe you can visualize that. This is an introduction to Breathe Easy Twin Blocks for treatment of sleep apnea to help you to stop snoring, sleep better, and breathe better. If you're a heavy snorer, this could save your marriage. Okay, there are 4 preformed occlusal blocks that are designed to cover the posterior teeth. And these are invisible twin blocks using preformed occlusal blocks enclosed in clear Essex appliances that are virtually invisible in the mouth. Modern Essex materials and pressure molding techniques, this simplifies the construction of invisible twin blocks, Breathe Easy twin blocks. I always like to try my own appliances. So I'm wearing these invisible twin blocks. And it does improve the airway and helps patients to breathe better. Now this may have applications to improve the airway in medical treatment for patients with breathing difficulties, or, for example, a patient having sleep apnea. In adult therapy, it may stop snoring. And this could be a useful approach for long-distance drivers to keep them awake when they're driving hundreds of miles. So that's another possible use for the Breathe Easy twin block. I have a new design for twin blocks, and to distinguish them from any other variations, I have put my name on them, Clark twin blocks, and they can be either removable or fixed. This represents another crossroads in the development of twin block technique. There are 4 preformed blocks, 1 in each quadrant. This shows the fitting surface of the blocks. The twin block kit contains a preformed palatal wire. It is one size fits all and is placed on the model before applying the blocks. We can make it narrower or wider as required. And we may, when we enclose it in the upper block, we may introduce a little expansion, a little at a time, perhaps at adjustment visits. We use the same principle in the lower arch with an adjustable lower lingual arch wire. Preformed twin blocks appliances are delivered ready to fit. There is a significant saving in laboratory time in making these appliances. This process takes 30 minutes compared to half a day to make removable twin blocks. The blocks are made passive on the models, but the upper wire can be adjusted to widen the maxilla. The appliances may be removable or fixed, and they are patient-friendly. They do not cover the palate, and they're also invisible. They may be combined with fixed appliances on the anterior teeth, and a utility arch may be fitted in the lower arch to control the lower labial segment. I'm working with my colleague, Dr. Samir Sayegh, and we are carrying out a clinical trial in his group of 9 orthodontic practices in Scotland. I believe this is the largest group in Europe, and Dr. Samir is studying the removable version. Now, we also have approval in the University of Dundee from the British Orthodontic Foundation. We have a grant to study the fixed version. It has been unfortunately interrupted by the coronavirus, which is changing all of our lives. But hopefully, if and when we control it, we will be able to get back to that study. Now, these are examples of patients treated by Dr. Samir Sayegh, and I say hello to Samir because he has also joined this course. And his Scottish orthodontic group is scottishorthodontics.com. This young patient is at an early stage in permanent dentition. The overbite is not deep in this case, and this is a mild Class 2 Division 1 malocclusion. This is the construction bite, the same as with the removable twin block, the conventional design. The construction bite is edge to edge with 2 millimeters interincisal space. The blocks are trimmed if necessary in the laboratory, and the profile improves when the mandible is advanced. 2 months later, there is a rapid improvement in correcting the distal occlusion, and this is reflected in the improvement in facial appearance and the profile. But do not be tempted when you see that rapid response to leave the twin blocks out prematurely. For me, 6 months is the minimum period in twin blocks. And as I said before, 9 months for a large overjet, or 1 year or more for a really severe case, for example, the 17 millimeter overjet. We need to give the mandible time to grow. That is important. This is a change after 4 months. So we have corrected to Class 1 molar and incisor relationship, overjet reduced, buccal segments corrected to Class 1. Keep the appliances in full time. Don't leave them out at this stage. It's too early. Now, fixed appliances were fitted to detail the occlusion, and this is a position after 4 months with fixed appliances. Treatment was completed in 18 months, and this is the finished occlusion with a fixed lingual retainer on the upper central incisors. A nice result, Samir. This 13-year-old girl is in early permanent dentition, good stage to treat, and she has a mild Class 2 Division 1 malocclusion with an increased overjet and slight anterior crowding. This is a construction bite registered edge to edge with 2 to 3 millimeters interincisal space. We may combine the fixed and functional stages of treatment in this case. Brackets can be fitted during the twin block stage to correct anterior crowding and align the anterior teeth. Now we have fitted upper and lower anterior brackets during the twin block stage to resolve the anterior crowding, combining fixed and functional therapy. When the patient attends for routine appointments, we can review the changes in the occlusion as we progress through the twin block stage. There is good facial balance, and now she has her fixed appliances. I would like to observe that I prefer to fully correct the distal occlusion before removing the twin blocks. I think it was a little premature in this case. I don't want my patient to be able to posture back into distal occlusion. The combination of anterior brackets and twin blocks works well to align the anterior teeth, and we can reinforce the class 2 correction by continuing with the twin blocks until, as I say, a minimum of 6 months, but longer if necessary. After 14 months treatment, we are in the finishing stage of straight wire technique, and treatment is completed in 18 months to an ideal class 1 occlusion with good facial balance. The objectives of treatment have been achieved. This patient requires a combination of twin blocks and fixed appliances to correct her malocclusion. This is the construction bite, and brackets are fitted during the twin block stage to correct the anterior crowding at the same time as we're correcting the distal occlusion and advancing the mandible. This is progress after 6 months treatment. These changes can happen very quickly at this stage in treatment. The anterior teeth are aligned while we correct the buccal segments to class 1 occlusion. I like to trim the upper block distally over the molars, and this will allow the lower molars to erupt and to control the overbite during the twin block stage. Combining the fixed and functional phases of treatment reduces the treatment time, and the patient is in retention after 15 months treatment. This ebook gives a comprehensive account of the evolution of functional appliances and advances in functional therapy and dentofacial orthopedics, including a comprehensive account of twin block therapy. This is the 3rd edition of my twin block book, available from JP Medical Publishers. Please visit my website for further information on ebooks, which represent a foundation course in orthodontics and functional therapy based on 50 years' experience in orthodontic practice. Whether you practice or teach orthodontics, this is an invaluable resource for interactive orthodontic education. So I hope you've enjoyed this introductory presentation on twin blocks. It is part of a continuing series in orthodontics and dentofacial orthopedics based on 50 years experience and innovation in orthodontic practice. This is the view from my studio, from our sun lounge, and I'm sitting here looking at that view right now, but unfortunately the weather is not so good in Scotland today. It is raining and windy, so I will not show you view today, but this is the view across the estuary of the Firth of Forth towards Edinburgh. So we move on now to the next part of the presentation. So let me just change the file here. And once again, we're looking at that view, and this time during the day. You see, you see in the foreground is a golf course, London Links Golf Course. Of course, Scotland is famous for golf, and we live just a short distance from St Andrews, which is the home of golf. And we're looking across the water towards Edinburgh. Scotland is a beautiful country, well worth a visit. And I have lived in this peaceful environment for many years. I believe we are at a crossroads in the development of orthodontics and dentofacial orthopedics. And we are advancing the future of orthodontics. So this is the occlusal inclined plane, the functional mechanism of the natural dentition. And twin blocks guide the mandible forward on occlusal inclined planes, using the forces of occlusion to correct the malocclusion. This session deals with twin block treatment of Class 2 Division 2 malocclusion. I would like to show you the first case I treated with a Class 2 Division 2 malocclusion with twin blocks. This severe Class 2 Division 2 with excessive overbite was a challenge in the early 1980s. There is a full unit distal occlusion, and the upper incisors are occluding on the gingivae beyond the lower incisors. There is a severe brachyfacial growth pattern of horizontal growth. The interincisal angle is close to 180 degrees, and the lower incisors are positioned 8 millimeters lingual to the apogonian line. This is a classic case for sagittal arch development by advancing the upper and lower incisors to release the mandible forward to correct the distal occlusion. This was partly achieved during twin block phase after 8 months treatment. This was a learning curve, and today I would continue with twin blocks to correct the vertical to an edge-to-edge incisor relationship. But at the time, this was a very satisfactory result in only 8 months of treatment. However, I was now beginning to learn the bioprogressive technique and philosophy using utility arches. But I didn't at this time have pre-torqued preangulated brackets, and treatment was completed with standard edgewise brackets. This shows the progress after 14 months treatment with twin blocks, followed by an upper sectional fixed appliance with a utility arch. There was insufficient torque and intrusion in the utility arch, so the result is not perfect, but is a vast improvement on the original occlusion after limited, simple treatment. This shows the steps in treatment. First with twin blocks, and then an upper fixed appliance to complete treatment. This was an excellent result in the early 1980s, when we still used standard edgewise brackets in bioprogressive mechanics with customized handmade utility arches to control the anterior teeth, before we progressed to the new designs of pre-torqued and preangulated brackets for precise finishing in straight wire technique. This is 3 years out of retention for that patient with excessive overbite. Treatment was completed in 2 years, including retention. The overbite was reduced and the interincisal angle improved, and the molars were corrected to class 1 relationship. This is a profile 3 years out of retention at age 16. We now look at the appliance design for sagittal twin blocks in treatment of Class 2 Division 2 malocclusion. For golfers, this is the hole-in-one twin block. We can add additional screws or springs to combine transverse and sagittal arch development. This is the two-screw sagittal. It is adapted to advance. Now, this is the three-screw sagittal. We have a midline screw posteriorly and two anterior screws to advance the incisors. But sometimes we only need a two-screw sagittal. It is adapted to advance the upper central incisors using two sagittal screws that are angled parallel to the buccal segments. In addition to advancing the retrocline incisors, activating the screws will increase the width of the buccal segments. In this example, the appliance is designed to advance 4 upper incisors. This design is appropriate in cases with blocked out upper canines. We activate the screws to advance 4 retrocline incisors first to accommodate the canines, then we may finish with anterior brackets in a finishing stage. So again, we're thinking in terms of combining fixed and functional therapy. So this is appropriate after we've activated the sagittal screws to advance the retroclined incisors. Control of the vertical dimension is important in correction of Class 2 Division 2 malocclusion. So the construction bite for this malocclusion is edge to edge on the upper incisors. As we advance the incisors and correct the distal occlusion with the sagittal twin block, we must trim the upper occlusal block to clear the occlusion over the lower molars to allow them to erupt. We progressively trim the upper blocks at each visit until the lower molars erupt into Class 1 occlusion. At the same time, we activate sagittal screws to advance the retroclined incisors. When the appliance is fitted, the occlusal blocks are in contact with the opposing teeth. At this visit, separating elastics are placed in the molar contex to free the molars to erupt. The upper block is trimmed to clear the occlusion over the lower molars to allow them to erupt. And this is similar to the management of Class 2 Division 1 malocclusion with deep overbite. At each visit, the upper block is trimmed progressively to allow eruption of lower molars. This is a typical example of a Class 2 Division 2 malocclusion with retroclined upper central incisors and deep overbite. The buccal occlusion is a full unit distal occlusion. In many Class 2 Division 2 malocclusions, the lower arch form is good, and this simplifies the treatment. The upper arch is narrow, and expansion is required as we advance the mandible. The first activation is to turn the sagittal screws to advance the upper incisors. The screws are turned twice a week, once in midweek and once at the weekend. It may be necessary to relieve the acrylic over the soft tissue lingual to the incisors. At this stage, distal occlusion is corrected and the overbite is reducing as the lower molars erupt. The next step is to add brackets on the upper anterior teeth during the twin block stage. This makes an easy transition into an upper fixed appliance to complete the treatment. When the molars have erupted into Class 1 occlusion, an anterior inclined plane is fitted with a flat occlusal stop to maintain the correct overjet and overbite during the support phase. When the canines and premolars erupt into occlusion. Alternatively, a bite guide may be fitted on the lingual of the upper incisors in the transition to fixed appliances. The overjet must be less than 3 millimeters to prevent the lower incisors from biting behind the bite guide. In the lower arch, I fitted a Wilson lower lingual arch during the support phase. This supports the arch form as the premolars and canines erupt into occlusion. The occlusion was corrected after 9 months, followed by a removable retainer. So we simplify the fixed appliance treatment by combining with the twin block phase. Most Class 2 Division 2 malocclusions have a brachyfacial growth pattern with a Class 1 or mild Class 2 skeletal base. It is not necessary to advance the mandible significantly to achieve a straight profile. For that reason, the construction bite is edge to edge on the incisors, and the appliance is designed to advance retroclined incisors. This is the 3-screw sagittal on the left, designed for transverse and sagittal expansion. The midline screw is activated once a week for transverse expansion, and the sagittal screws converge to maintain contact on the central incisors as the arch expands. They may be activated twice a week to advance 2 or 4 incisors. On the right, the 3-way screw provides both transverse and sagittal activation. Either design may be used to advance 4 retroclined incisors to accommodate buccally displaced canines. We can now review the management of buccally displaced canines. This young girl has good facial balance with a slightly flat profile. Her upper canines are blocked out of the arch mesially and buccally, and this spoils her smile. This shows the crowding in the upper labial segment with blocked out upper canines. The lower arch form is good, which simplifies the treatment. There is a full unit distal occlusion with retroclined upper incisors. With good facial balance, it is better to expand to accommodate the canines rather than resort to extractions. Bite registration for a small overjet with a full unit distal occlusion. We may not go fully edge to edge. The upper twin block has a 3-way expansion screw with an additional midline screw to support transverse expansion. The distal occlusion is corrected after 10 weeks, and advancing the upper incisors is providing space to accommodate the upper canines. At this stage, an upper transverse expander is fitted to continue transverse expansion and is adjusted to continue to advance the upper incisors. The distal occlusion is corrected at this stage. This is combined with an upper fixed appliance to expand the upper arch and align the upper anterior teeth. The fixed appliance with delta force brackets is used to detail the occlusion. The prescription of these brackets is favorable for non-extraction therapy. There is good torque in the upper incisors. This is a reminder of the original malocclusion with a full unit distal occlusion and blocked out upper canines. This is the occlusion after treatment. The canines are accommodated after a short period with twin blocks to correct the distal occlusion, followed by a transverse expander and an upper fixed appliance to complete treatment. The upper arch form has improved with transverse and sagittal arch development to accommodate the blocked out canines. And the improvement in appearance is immediately evident when she smiles. And now, this young lady has balanced facial proportions with a classic straight profile. The objectives of treatment extend beyond orthodontics to include facial balance and harmony. Now we move on to review a Class 2 Division 1 subdivision with a single proclined incisor. The skeletal pattern is Class 1 with a mild retrognathic profile and a convexity of 3 millimeters. There is full unit distal occlusion and increased overjet with a single upper incisor proclined and resting outside the lower lip. The appliance design includes midline screws and lingual wires to advance the 3 retroclined upper incisors. This is a diagram to illustrate the design of the upper support appliance. The anterior inclined plane supports the corrected overjet, and the flat occlusal stop supports the corrected overbite, while the lower incisors and canines erupt into occlusion. The anterior inclined plane extends to engage the lower incisors and canines, and a labial bow is added to retain the upper incisors. This is the retainer. Twin blocks were worn for 10 months, followed by 4 months with the support appliance, which is worn full time to support the occlusion as the occlusion settles. And this is the corrected occlusion after 14 months treatment. Once again, there is a well-balanced straight profile after treatment. 1 year later. This is the cephalometric tracing before treatment for this patient, a single proclined upper incisor, and there is mandibular retrusion with a full unit distal occlusion. The superimposed tracings show a favorable improvement in the profile with a small mandibular advancement. This is another variation on the Class 2 Division 1 subdivision, malocclusion with a single retroclined upper incisor. One upper incisor is trapped inside the lower lip, while the other central incisor is proclined outside the lip. The mandible is trapped in distal occlusion by the single retroclined central incisor. This type of malocclusion responds very quickly when the retroclined incisor is advanced with a lingual spring. The mandible advances to unlock the malocclusion within 2 months of starting treatment. But don't be tempted to leave the appliance out too quickly. This is a postured position in the early stage. There is rapid improvement in appearance as the mandible translates forward, and this is evident in the front facial view, and equally in the profile after 2 months treatment. This was one of my earliest twin blocks patients, and at this stage I did not include a midline screw in the upper twin block. Treatment was completed in 9 months with a good improvement in facial appearance and the profile. This was a learning curve, and evidently midline expansion would have improved the buccal segment occlusion, so I always include a screw for that purpose. The final result out of retention at age 19 shows good facial balance and a straight profile. This is another example combining twin blocks with bioprogressive technique in late mixed dentition. Most patients with class 2 division 2 malocclusion have a class 1 or mild class 2 skeletal base with a straight profile. This is another patient where twin blocks are combined with bioprogressive technique. Today it would be straight wire technique. This girl is 12 years old in late mixed dentition and has a class 1 skeletal base relationship. The upper incisors are retroclined with deep overbite. A typical class 2 division 2 malocclusion. The mandible is trapped in distal occlusion by retroclined upper incisors, and upper lateral incisors are proclined and rotated. The sagittal twin block is used to advance retroclined upper central incisors, and it must be trimmed clear of the lateral incisors. So we are widening the arch with the midline screw and advancing the incisors. After 6 months with sagittal twin blocks, the distal occlusion is corrected and an upper sectional fixed appliance is fitted with brackets on the anterior teeth. As the premolars erupt into occlusion, the next step is to fit a customized double delta utility arch to torque and intrude the upper incisors. Finally, a lower fixed appliance to torque and intrude lower fixed appliance with an upper finishing arch. The double delta arch is an example of the range of utility arches designed by Dr. Ricketts for sectional control in the labial segment in bioprogressive technique. This preceded straight wire technique and was designed for interceptive orthodontic treatment in mixed dentition. I traveled and lectured with Dr. Ricketts in both Europe and South America. I did 2 tours with him because I learned bioprogressive technique from Dr. Gugino, and that enabled me to improve my fixed appliance technique. Straight wire is simpler, of course, but I enjoyed bioprogressive technique. Equally important was the lower utility arch for control of the lower labial segment, in this case used with an upper finishing arch, adapted for intermaxillary traction. This was a beautiful mechanical system that did not require full bonded appliances in both arches, thereby eliminating frictional forces. The technique was adapted for use in mixed or permanent dentition. The cephalometric analysis after treatment confirmed that the objectives of treatment were achieved. In bioprogressive philosophy, Ricketts recommended that the upper incisors should be parallel to the facial axis after treatment, and the lower incisors should be in the range of +1 to +3 millimeters to the A-Pogonian line. Superimposed tracings confirmed that this was achieved with slight mandibular advancement to correct the distal occlusion. This is the facial appearance before and after treatment, and the finished occlusion out of retention after detailing with bioprogressive technique. This shows the change in profile before and after twin blocks and on completion of treatment. The major improvement occurred within 6 months during the twin block stage. Now we look at a challenging Class 2 Division 2 malocclusion with severe crowding. Before treatment, the mandible is retrusive in the profile. and there is a severe class 2 skeletal discrepancy, a convexity of 9 millimeters. This is strong brachycephalic growth pattern, a combination of maxillary protrusion and mandibular retrusion. The interincisal angle is close to 180 degrees with an excessive overbite. The tip of the lower incisor is 7 millimeters lingual to the apogonian line. This is a severe malocclusion. There is severe crowding in the lower arch with 16 millimeter arch length discrepancy. In diagnostic terms, this would allow the lower incisors to be advanced from -7 to +1 to the apogonian line to resolve the crowding. However, I was treating this patient in National Health Service with an administration that was committed to extraction therapy, and I could not obtain permission to treat this patient without extractions. Therefore, the only question was, which teeth to extract? The lower right canine was distally inclined and blocked out of the arch. I decided to extract the lower lateral incisor to allow the canine to upright to be accommodated in the arch. In the other 3 quadrants, first premolars were selected for extraction. Sagittal twin blocks were used to advance the upper incisors and release the mandible to advance to correct the distal occlusion. This was followed by sectional fixed appliances to align the labial segments and detail the occlusion. The superimposed tracings show significant mandibular growth and improvement of the lower incisor relationship by advancing the upper and lower incisors. This is not an ideal result, but there is a vast improvement in the profile and the occlusion compared to the original occlusion. The major improvement in the profile occurred during the twin block phase, and this was maintained out of retention. The next patient has severe labial crowding. What are the guidelines to accommodate anterior crowding? The positive factor is that this patient has a good profile. The cephalometric analysis confirms that the upper incisors are retroclined and the lower incisors are 2 millimeters lingual to the apogonian line. The convexity of 5 millimeters is mainly due to mandibular retrusion. Looking first at the models, there is a full unit distal occlusion in the buccal segments with retroclined upper incisors. The occlusal view confirms the extent of labial crowding in the upper arch, and there is significant crowding in the lower arch, which may be secondary to the labial constriction of the upper arch. The question is, to extract or not to extract? This patient was treated by Dr. Gordon Klusak, who was the first doctor on the American continent to learn about twin blocks and arch development techniques when he came to a course in Scotland in 1990. He went back to his pedodontic practice in Canada to put these techniques into practice, and he was expert in twin blocks and arch development. How would you treat this patient? He decided to maintain the favorable profile in a non-extraction approach. That was quite heroic. Crowding can be resolved in the upper arch by advancing the retroclined incisors. This will free the lower labial segment, and the lower incisors can be proclined to resolve the crowding. Taking into account the strong profile and the cephalometric analysis, he carried out the first phase of arch development using Wilson modular lingual appliances, which he learned in my course in Scotland. This significantly improved the arch form. It was now possible to construct twin blocks to correct the distal occlusion. The response was positive, and this is the occlusion after twin block phase. This was heroic treatment. The cephalometric tracings before and after treatment showed the correction achieved to class 1 occlusion with a positive improvement in the profile. The upper incisors are proclined and almost parallel to the facial axis. The lower incisors are in the stable position 1 millimeter ahead of the apogonian line after treatment. The superimposed tracings confirm that the profile improved by mandibular advancement. This is confirmed in the facial photographs. A combination of lingual arch development and mandibular advancement produced a positive response in the occlusion and the facial profile. These are the principles of twin block treatment of class 2 division 2 malocclusion. The construction bite is edge to edge on the incisors. We use sagittal twin blocks, a midline screw to adjust arch width if required, in addition to the sagittal screws, advance retroclined incisors, erupt lower molars to reduce overbite, correct the distal occlusion, add brackets on anterior teeth if required. Support phase is to maintain the overjet and overbite and can be followed with detailing with fixed appliances. I hope you've enjoyed this introductory presentation on twin blocks. It is part of a continuing series in education in orthodontics and dentofacial orthopedics based on over 50 years experience and innovation in orthodontic practice. Thank you for your attention, and I wish you success with twin blocks. And we will move on to the next session, I think in half an hour's time, but your team will advise you of when we will start the next session. Please, if you have questions, you have to pass them on to your organizer. So I'll see you shortly to answer questions and to continue with the next phase. Thank you for your attention.